addition, he is also the Associate Professor of Intelligent Systems Program, as well as the Clinical and Transitional Science Institute at the University of Pittsburgh. Shyam did his MBBS from JIPMER Pondicherry, and then did a year or so of training in anesthesia before he decided to move to the US, and he did his MS in Physiology and Biophysics at the University of Illinois. Following that, he did his residency in neurology at the Boston University Medical Center at Boston. After practicing neurology for some time, he decided to pursue his interest in artificial intelligence, and he did his MS and PhD in artificial intelligence at the University of Pittsburgh. And after that, he has continued to work there. So thank you, Shyam. And it's my privilege to introduce Dr. Mahendra Bhandari, not that he needs introduction for most people. Sir is the Director of Robotic Research and Education and the CEO at the Vattikuti Urology Institute at Henry Ford Hospital at Detroit. Sir is also the advisor for ReadyMinds Research, which is an AI company. He did his MBBS from Sabai Mansingh Medical College and moved to the south when for his urology training at CMC Vellore. Following that, he started the Department of Urology at JIPMER, and he was our teacher. After working as the director of the Sanjay Gandhi Postgraduate Institute at Lucknow, Sir was the Vice Chancellor of Medvarsity at Apollo Group of Hospitals, and subsequently the Vice Chancellor of King George Medical University at Lucknow. Sir was awarded the B.C. Roy Award in 1996 and the Padma Shri in 2000. He started the Indian Journal of Urology and was the founder editor. After retiring, when people think of taking it easy, Sir actually did his MBA from the Ross School of Business, University of Michigan, and since 2010 he has been associated with the Vattikuti Foundation. There is no area which Dr. Bhandari hasn't explored, starting from urology, medical training, hospital administration, robotic surgery, medical ethics, name it, and Sir is involved in that. So he has also received the President's Award at the American Indian Urological Association, and his professional visa is on display at the Smithsonian Institute of National Museum of American History, which recognizes immigrants who have made significant contribution in the US. Welcome again, sir, and thank you so much for joining us. Over to you, Shyam.
Okay. Can you see the first slide?
Yes.
Okay. Okay. Thank you, Vidya, for the introduction, as well as connecting me up with Dr.
He's from the University of Pittsburgh.
As well as giving me an opportunity to talk about artificial intelligence. So I've been, I think, yep. So I've been, I think, working in this now for close to 20 years. And what I'm going to do today is I'll give you just a very brief overview of where AI is headed in the healthcare field. It's exponentially increasing as days go by. But I'll start with some basic reasons as to why we even need AI. So I'll talk a little bit about the need for the AI, because understanding why we need AI makes it easier to understand when you see AI being introduced in clinical care, whether it makes sense to actually have the AI there. I'll only talk very briefly about the various technologies in AI. It just keeps exploding, the kinds of technologies that are now available in AI. I'll give you some examples of AI which are deployed, as well as some which are in research, and maybe a little purview of what's to come in the future. And then I'll talk about the challenges of AI, which I think is critical to talk about, because what you typically hear is a lot of hype and not that much about the challenges of using AI. So to start off with, the two main areas of application of AI in biomedicine are basically biomedical discovery and for clinical decision support. So biomedical discovery is where we see a large amount of applications. So AI is now being used in the analysis of large amounts of data. And as we know, in biomedicine, we are kind of moved from clinical data to all kinds of molecular data. And there are lots of this data coming out, things like genomics and proteomics. And the standard statistical methods are not sometimes capable of analysis of this data. And so we are starting to use more and more AI. A second area which it's starting to come in is clinical decision support. So CDS is basically the technology which provides physicians, patients, even public health officials with knowledge and information which can enhance the decision making. And so here I'm going to focus pretty much on the CDS component of AI, because that's what, as clinicians, we see at the point of care. So what are the challenges currently in clinical medicine for which AI could potentially help? So number one is knowledge overload. Since the time we kind of went through medical school, knowledge has been exploding, medical knowledge. And a lot of this is coming from the molecular basis of medicine. The current classification of medicine that we use is clinical pathological classification, and that's how all the specialties are arranged, and that's how we learned all the medical knowledge. But the new classification, which is now coming out, is this molecular classification. And keeping all this knowledge in our heads is going to be almost next to impossible. So as an example, here is a classification for breast cancers, which is histology based. This is the kind of things that we learned. And this is the kind of classification that clinicians still use. But what's coming up more and more are these molecular classifications. So this is the molecular classification of, say, breast cancer, and this is based on genomic information and proteomic information, and trying to understand what are the molecular changes which are responsible for a particular cancer. It's almost impossible to keep track of these things. And so having computers which can take this knowledge and deliver it at the point of care is one important area where AI can help. And as we go along, we're going to kind of see this dual classification of disease, the clinical pathological classification and the molecular classification kind of live side by side for a while. And we'll kind of need both to do precision medicine. The second area is data overload. And what I mean by this is that the amount of data that we are starting to collect per patient is increasing. So as an example, in a critical care, anywhere up to 1,400 new data points flows into the electronic health systems per patient per day. And there is enough evidence now to show us that as human clinicians, we sometimes miss some of the import of this data because so much of this data is coming through, and the electronic systems that we use aren't really helping us in collating all this data together. And this comes from the fact that there are limitations to our cognitive capacity. So our brains can only handle a small number of variables together. As we get more and more experienced, we can chunk a lot more information and chunk them together, but you're kind of still only handling anywhere between 10 to 20 variables at a time. And that was okay when we went through medical school and residency training, because a lot of the data was standard clinical data that we got through physical exams, history, as well as, say, the standard lab tests. But over time, now what we're starting to see is all this molecular data coming in. So the first kind of molecular data was coming from the DNA sequence when the human genome was sequenced. And now pretty much it's inexpensive enough to sequence an entire genome of a person. And this is often done in pediatrics sometimes to get a diagnosis. So all the mutational information which flows through the genome is one area where data is starting to flow in. And then on top of that, we have functional genetics, which is basically expression of the genome, the amount of RNA that you have in a particular tissue or even in a particular cell. So we are starting to now move into single cell functional genetics. And then furthermore, there are all these other kinds of molecules like the proteins and the metabolites. And these can also now be measured across all possible molecules in a single person. So putting all of this together, it's quite difficult for us to consume all this data and make sense of it. So having computers which basically can see this kind of data for a patient and put them together and bring the knowledge to bear on them, and then show that to the human clinician would be another area where this would be very useful. And then finally, there is this process overload. This is especially true in the US, where clinicians are spending enormous amounts of time either entering data into the electronic systems or trying to go through the electronic health system and figure out what's important data. So as an example, some of the primary care physicians spend somewhere up to 6 hours of 11-hour day. That's half their time. Is basically interacting with the electronic health system. Now, this is kind of US specific, but this will probably slowly expand across other parts of the world too. So here is a graph which basically shows the amount of text or characters that is there in a clinical note in a clinical office. So in the light blue, basically this is the distribution, what we see in the US context compared to the dark blue, which we see in the international context. So internationally, this is not that big a problem yet because the amount of notes which are being entered into these systems is still tractable. In the US, it's come to the point it's intractable, and anywhere up to 50% of physicians are showing burnout. And one of the reasons is because of the immense documentation that they have to do. And in turn, once they document all this, it doesn't seem that it helps them that much in clinical care. So all that information goes into this black hole and seems to be not very useful when they actually want to make decisions. So with that kind of three reasons, I think, why we need AI, I will kind of move into a very brief introduction of what AI is. So one way to, at a very high level, to look at AI is to look at its focus or application area. So based on that, we can consider AI as narrow AI, general AI, and super AI. So narrow AI is basically where we use computer systems or computer algorithms for a very defined single task. An example of this is like the Google search engine. It's a very focused single task, and it's taken us like 20 years. It's taken Google 20 years and billions of dollars to get it to a point where it's reasonably good. General AI is basically building computer systems which are somewhat similar to humans. So humans have the ability to solve a whole range of tasks, often with incomplete data. The idea for general AI is, can we replicate that kind of intelligence in machines? And then finally, there is super AI. So super AI, the idea there is that we want to build computer systems which would basically be more powerful than any single person, and can incorporate all of humanity's cognitive capacity, or even more. That is, they might even be able to do things that humans can't even do. And now, to make an analogy between, say, something like self-driving cars, where AI is quite advanced, to, say, medicine, here is a cartoon which comes from a paper that Eric Topol published a couple of years ago. So there is a spectrum on which AI sits. So from the left to the right, as we go, we start with almost no automation, and then we can have partial automation all the way up to full automation. And Eric Topol basically splits it up into kind of two big categories, where on the left-hand side, you have 0, 1, and 2 categories. So here, the AI is helping the human, while the other category is where the human is kind of helping the AI. That is, the AI is playing a more important role. So in cars, the cars that we had about 20 years ago are cars where we would say there's no automation. And then now, if you look at the cars, many of them have some level of automation. So we started out with things like partial automation, where you would get alert signals if you, say, shifted out of your lane, and it would warn you that you shifted out of the lane. And then we went into partial automation, where you can basically have something called cruise control, which almost everyone uses nowadays on the freeways, where it automatically sets the speed and all you do is just steer. And then finally, we now see cars like Teslas, which are fully automated. So they can pretty much drive themselves. So similarly, in healthcare, we can think of similar levels of automation. And where we currently sit for most clinical use is somewhere at level 0. That is, there is no automation. Maybe there's a little bit of level 1, which is assistance. The assistance that we get are things like alerts that if you are in the ICU or using anesthesia machines, for example, you get these alerts. More often than not, they're distractions rather than true assistance. So compared to something like cars and even planes, the level of automation in medicine is still very, very low. And in terms of the 3 AIs that I talked about, the narrow versus the human level AI versus the super AI, what we know so far, even from other domains, is that narrow AI has been successful to some extent. We have not been successful in making AI at the human level. So having like robots, which can basically handle any tasks that humans can, has not been possible so far, though it has been a dream for about 60 years now since AI started. So much of the focus in healthcare for AI is also in the narrow AI space. And the idea here is that most of the successful applications of AI, you can imagine AI as raisins in a loaf of bread, and the raisins are the AI. They are kind of this little pieces which are the principal source of nutrition, and they can do some very specific task well enough. And so we stitch together a whole lot of these raisins to kind of make a more intelligent healthcare system. But the idea is not to really replace human physicians with AI systems, because it doesn't seem it's possible, at least in the near term. And this is just to give you a very brief idea of these terms that you often see, which is AI, artificial intelligence, machine learning, or ML, and deep learning. These are the three commonly used terms. The simplest way to think of them is AI is the name for the entire field, which is looking at developing computer programs with the ability to learn and reason like humans. Machine learning is a subset of the AI field. And the idea of machine learning is that the algorithms and the intelligence that we build in the machines are being done from data. So these are, and machine learning is very close to statistics. So a lot of statistics, that's what we do is we take a lot of data and we try to make inferences and draw conclusions. So machine learning is the ability to use past data and then encode it in a form that the machine can then take decisions. So instead of explicitly programming the computer, you're basically using past data to drive the computer. And deep learning is a subset of machine learning. And it uses a particular kind of technique called artificial neural networks. And these have been shown, at least in some scenarios, that they can learn from vast amounts of data to an extent that they can surpass human capacity quite well. So for example, in playing games like chess and Go, deep learning methods are able to surpass humans very quickly. And then in terms of imaging, so like things like clinical imaging, retinograms, deep learning seems to be doing quite well. It's still not completely surpassed human clinicians, but it's getting close. So deep learning seems to be pretty good for certain kind of tasks, especially tasks which involve images. Okay, so with that, let me kind of give you some examples of AI to make all this concrete. And I'll kind of split this up in terms of the three needs that I talked about in the first part, in terms of knowledge overload, data overload, and process overload. So developing CDS for knowledge overload, this has been going on for a while. In fact, this is the oldest area of application of AI to medicine. So here's an example of a diagnostic support system. And this is the area that AI first started to get into medicine, is to see whether we can build computer systems which can diagnose. And even after 40 to 50 years, there are really no diagnostic systems which are completely deployed. And I think the main reason is because bulk of medical training is focused on diagnosis. So it's a tough bar for computers to cross, because we spend 4 to 8 years basically spending bulk of our time in doing diagnosis. But even then, there are now studies basically showing that human doctors sometimes miss certain diagnoses, especially rare conditions given a particular set of signs and symptoms. And one example of this is the Isabel system. And this system was actually developed because there was a person in the UK, Jason Maud, who had a 3-year-old daughter who came down with chickenpox. And the physicians failed to pick up the complication of necrotizing fasciitis. And then the kid passed away. So, so he basically drove the development of this system, which is more commonly used in places like the emergency department and some of the physician offices. And the idea here is that it can take in the information that you have about a patient who comes in, and then it basically lists the differential diagnosis. And the idea here is that it'll flag down things that you should not miss, or at least look into. So the idea here is basically to help the physician not to miss something critical, which might be life-threatening. And this has been actually deployed in, I think, quite a few places, both in the UK and in the US, and is used to some extent. More commonly, what we see now, where genomics has come in, the biggest place that genomics is used in adult medicine is in pharmacogenomics. So basically knowing that you might have to adjust the dose of a drug or even use a different drug based on a particular genetic variant that the person might have. And this is one area which is, it's impossible even for pharmacists to carry all that information in their head in terms of what genetic variants require what kind of dose adjustments. And so what we now see, which is implemented in a rather crude fashion in the electronic medical systems, is if there is genetic information available for a patient and it's relevant for a particular drug that you're prescribing, then it will pop up an alert. So here is an example for clopidogrel, Plavix, which depending on particular variants, you might not even want to use because it may not be very effective. So if you're a high metabolizer of this drug, either you have to increase the dose dramatically for this, or you basically change to a different agent. And then a place where AI has made a lot of inroads is in imaging and basically doing diagnostics on imaging. So here's an example of a CT scan showing a subarachnoid hemorrhage. And on the right, what you see is an AI system, which basically shows you where the hemorrhage is. And so this is basically helping the radiologist at the time that these images come through. So the interesting thing about stroke and imaging is that because timely intervention in strokes is now very critical, given that we have antiplatelet therapy as well as clot busting therapy as well as now thrombectomy. And if you can get the person in time into the hospital, you can actually have very good outcomes. One of the newest AI systems here is, this is basically similar to what I showed in the last slide. It's a AI system which looks at every CT scan that is done for stroke and is able to detect large vessel occlusion, because this is the one where thrombectomy can pretty much get you to very, very good outcomes, but you have to kind of get it done within the first 4 hours. And so this system is actually now deployed. It's FDA approved, and it's being paid for by CMS. This is the first time that the Centers for Medicare in the United States, which is a government insurance, which pays for procedures and everything that we do in healthcare. This is the first time that they're paying for an AI system, just for the AI system alone. And the interesting thing is that they're not paying this for the system because it's better in diagnosis compared to the radiologist. What it is better at is the ability to inform the entire stroke team much faster than humans can. So essentially what it does is, it's looking at the images the same time that the radiologist is looking at, and then it blasts out basically alerts to the entire stroke team so that they can come together quickly and make a decision. And so they're able to save up to an hour's worth of time to get the patient into the thrombectomy suite. And that's why the CMS is paying for it, not because it's more accurate. So the sensitivity and specificity actually, it works at pretty much at a radiologist level. It's not better than a radiologist. Here is one which works on EEG. And EEG, continuous EEG monitoring is often used for, say, in the ICU or in hospital seizure detection. And so what the system basically does is it's looking for spikes in the EEG, which are hallmarks of seizures. And this is another FDA-approved algorithm, and it's quite extensively used. And it doesn't perform any better than the humans. It performs at the same level. The main advantage is that it can constantly be running as the EEG is being recorded. And so it's more timely, in its ability to detect something and then alert a physician who can then come and look at the patient. Okay, so those are some of the examples of kind of diagnosis-oriented AI. And there are somewhere up to 50 to 60 such systems which are now approved by the FDA in the United States, of which only one is actually being paid for, the stroke detection one, by the insurer. And we'll probably see more of this come down the pike. This is the area where there's maximum expansion of AI happening. So the second area is the data overload problem. So you have all this data for patients flowing into the electronic health systems, and these systems don't do a very good job of putting the data together in a way that's useful to the clinical user. So here is an example which was developed by IBM of the Jeopardy fame. The idea here is that you have all this data in the EMR for a patient, and you want to be able to summarize this in a visual way, because humans typically can process visual information far faster and far better, and you can consume a lot more information in a visual format than in the text format. So the idea here is that you would have these various conditions or chronic problems that a patient has, which is at the top. And then if you were to click on one of those, then you have these all the data which is kind of arranged in these bars and gives you a summary overview which is relevant to that particular condition. So you have things like acute events on a time scale, abnormal lab results. In this case, it's hemoglobin that you can see over time, treatments that have been given, which is relevant to anemia, any contributing factors, any symptoms or complications related to anemia. So the idea here is that if a person comes to the outpatient or to even the emergency department, a clinician can pull this up and see this summary very quickly. And then the user can then click through all the other problems that the patient has and very quickly be able to look at the entire information of that patient. Because this is one area where more and more we know that in the outpatient especially, it takes a lot of effort and time to actually get all the information and the history of this patient from the EMR into your head. And so trying to help with that is kind of an important problem. And then in my own lab, we have something similar going on. So this is basically an overview of a patient in the critical care in the ICU. And the idea is that we chunk this data up. So you have all the physiological measurements on the left-hand side, all the medications in the center, all the lab values right in the center, and all the kind of the clinical notes on the right-hand side. And the idea is that you can look at this, say in the morning before rounds, and it will display the history in a visual format. And on top of that, it uses AI to basically highlight some of the data items that the machine thinks is important. Currently, what happens with ICU systems is that you have very simplistic rules, which says that if your lab value is out of range, then you have an alert or it gets marked. But we know that in the ICU, almost everything is out of range. And most of them are not important for the current problem that you're looking at. So you need to have the machine be smarter than do some very simplistic things, which just tells you that something is out of range. It needs to understand the clinical problem that the patient has. It also needs to understand what's the problem that the clinician is interested in. So a pharmacist is interested in something very different than a nurse, than a critical care physician. So we are basically building a system which uses machine learning to understand that and kind of highlight important pieces of information that you might want at the time that you're going to make decisions. So this is a system which is built for anesthesia. And this is tackling the problem that it's trying to predict whether the patient will become hypoxemic over, say, the next 5 to 10 minutes. So the idea here is that on top, you have the standard kinds of display that anesthesiologists use, which are looking at physiological parameters and respiratory parameters. And then at the bottom, you have this AI system, which is basically giving you an odds ratio as to whether this patient is going to get hypoxemic within the next 5 minutes. So this is basically looking at all the information that you get through a standard anesthesia system, and also probably a little bit more like what condition the patient has and what kind of procedure the patient is undergoing. And it's then drawing this curve for you so that if it's high, if the probability or the odds ratio is high, then you might want to intervene early on. So one of the interesting things about the system is that it's, okay, it's good to kind of have something which tells you that the probability of developing hypoxemia is going up. But often that is not sufficient to know like what you need to do, because hypoxemia can be driven by many factors. So what this system does is it basically also tells you what is driving the high odds ratio of hypoxemia. So 2.4 in this case at this point in time is high. And it's kind of telling you that here are like 3 factors: high BMI and low tidal volume. The machine thinks are the 2 critical pieces which are driving up the odds ratio. On the other hand, the normal pulse is driving down the odds ratio, and then it just lumps all the other factors together. So this basically does 2 things. One, it provides a reference for a human to look at it and understand whether the machine's predictions make any sense in terms of what you would normally reason clinically. So it provides clinical reasoning so that you can have more trust in what the machine is saying. And then the second thing it does is that some of these factors that come up here tell you what kind of interventions to use. So if it's high BMI, you can't do an intervention for that because that's not fixable there. But if it says low tidal volume, now that's a fixable issue. And then this is kind of more futuristic. So in the operating room, one of the key challenges, which is kind of similar to the ICU, is that there's a lot of monitoring which is going on, and a lot of integration needs to happen. So currently, you have anesthesiologists, sometimes you have neurophysiological monitoring going on, and then you have imaging, and then the surgeons themselves. And integrating all this information is currently done by humans. So that's why we need to have a team which is very closely integrated, and they can pass relevant information from one person to another. The idea here is that in the future, can we have the machines actually do this integration? So these machines will be consuming everything that's being measured: the anesthesia machines which are measuring things, the things that the surgeons are doing, the images that are being used during surgery, and then be able to provide some guidance which would be context aware. So it can provide guidance to anybody on the team, whether it's a nurse, the surgeon, the anesthetist, so on and so forth. And then, given that there is a lot of rise in surgical robotics, currently most of the robotics are basically merely an extension of the human surgeon in terms of manipulation, basically. So the idea of a cognitive robot is that it can actually receive all this information and be able to do tasks a little bit more autonomously. So you could basically, as a surgeon say, close up, and the robot will be able to do the entire close up, rather than currently what happens is that the surgeon actually does the entire close up using the robot. So these are things which are kind of more futuristic, and these are being driven by similar advances in other areas, like, say, an airplane's cockpit, where a lot of information flows through and the computer systems integrate it and then present it to the pilot. Okay, so with that, I'll just go over very briefly over the process overload. So for process overload, currently, the things that are being tried out in the US is this whole idea of medical scribes. So this is a very interesting development, which is kind of crazy, which is because so much data entry needs to happen in clinical encounters in the US, that they actually employ people who just listen in on the conversation and then transcribe that into the computer systems. So instead of having a human do it, which is what is currently happening in places like the emergency department, the idea here is that you would have computer systems which will listen in on you and then be able to basically decipher what the physician is talking or the patient is responding, and then put it into the clinical notes. And this is being actually tried out here in our hospitals as a research project. The ability to see whether you can take technologies like, say, Alexa, which can listen in on a conversation and convert it into text that can go into the EMRs. Okay, so that was just a very brief set of examples, and there are many, many more, a lot of them on the research side, but some of them slowly coming into actual use. But with that, let me move on to the challenges. The challenges of AI are starting to be looked at, but they're not that widespread in terms of information that people know about. A lot of times what we hear is how well an AI system works. What we don't hear about is how badly they can fail at times. So I'll just touch on 3 challenges which need to be solved before we can trust AI in clinical use. So these are transparency, fairness, and robustness. So transparency, I kind of touched on this when I gave you that example of predicting intraoperative hypoxemia. So a lot of the current AI systems, what they do is they only kind of give you this prediction. So they might predict that you're at high risk of developing something, or they might predict that you currently have this. What they don't give you is some kind of an explanation. So one of the goals of making AI transparent is that in addition to its prediction, it needs to provide an explanation. And that explanation has to be something which is clinically consumable. So in this particular example, you need to be able to explain the prediction in terms of clinically usable variables that we normally use in reasoning. And for a lot of problems, this is a high bar for the AI systems. But more and more, it's being recognized, not only in medicine, but also in other arenas, like when AI systems are used to make decisions about giving, say, mortgage loans. You can't just say that the AI system told me to reject the loan. You have to give an explanation. And moreover, in Europe, there are now laws in place which says that any AI system which is used for clinical decision making needs to have explanations, so that if somebody goes back and asks for an explanation, there needs to be an explanation which is provided. So this is a very important area, so that if you come across AI systems which are embedded in clinical care, one of the first things you've got to ask is, does it have the ability to provide explanations? And if it doesn't, really you have to ask the question, would you even trust it? A second problem is fairness. Now, fairness has been a problem. So fairness is basically the issue where um, for certain subgroups of the human population, um, we don't have that much either medical knowledge, or the current treatments which are in use are really not that useful to those populations. So typically these would be like minorities. In the US, it would be like the Black population, for example. Almost all medical research was done pretty much on the Caucasian population, and they may not readily transfer to the Black population or even to the Asian population. And so this is something widespread in medical research per se, the ability to take things that have been discovered for one population and hope that it's applicable to other populations. You really have to validate it in the other populations. So with use of AI on large amounts of data to make these predictive models, there is a concern that unless we evaluate these models specifically for populations that are minorities, we wouldn't even know how well it performs. So here is a very simple example, and this is not in the healthcare field, but this is just in the facial recognition field or the gender detection field. So here are basically 3 algorithms which these companies have developed, and they basically, these are actually used for certain tasks out there. And when someone went and evaluated them specifically on darker people versus lighter people, they found that in the darker females, it does really poorly in recognizing the gender. And this was not known before it was deployed. And so this is actually a paper by this person called Gebru, which you might have heard of recently. She was in Google. She actually comes from Africa, and she pushed a lot for fairness. And recently she was fired from Google, probably because she was forcing too hard on the fairness domain. And then robustness is basically the idea that that the AI, which typically are built on statistical models, these models need to be robust over time as well as across geographical regions. And this goes back to standard medical research. So if you look at things like, say, the Framingham risk model for cardiovascular disease, the 10-year model, it had to be tweaked a lot when the model which was developed in a Caucasian population in Massachusetts was being applied to, say, a Black population or to the Asian population. It didn't work that well, and it had to be tweaked to make it work. So the same thing applies with AI models, is that they might have been developed at a particular place on a particular population. And even if you use it in the same place, you do have to monitor them constantly to see whether the performance is still good enough to be used. So here's an example which says that the model was trained or developed and it's been used, and then over time you can see that it starts to fall down in its accuracy. And so once an AI model is deployed, you need to have constant monitoring of these models. So this is very similar to what the FDA does for drugs and therapeutics. So once the drugs are deployed or the vaccine is deployed, the FDA continues to monitor that drug for new side effects or for new problems. If anything, on the AI side, that monitoring has to be even more frequent to see whether there is a problem in the way that the model is working. Because fundamentally, our current AI technology, what it's basically doing is it's capturing old knowledge, because it's taking older data and it's capturing the knowledge from the older data. And we are applying this in the future. And things can change in the future. The practice of medicine could change. The kind of population that's coming to a particular place could change. And the model may not be working very well on the new population. And so there can be a variety of reasons why the model fails. And unless these models are, or the AI systems are constantly monitored, we wouldn't even know that they are starting to fail. So this is kind of an important area which currently not much attention is being paid to. So the FDA has approved like 60 plus algorithms, and it's not quite clear what is it that they're going to do to make sure that it's being monitored in the future and making sure that it actually is working properly. But there's a lot of ongoing discussion in the FDA in terms of how to tackle this. So those are kind of the three major challenges, but there are some more other challenges, but I think these are the three critical challenges that need to be understood and need to be fixed before we can actually use AI in a safe fashion. So with that, I'll just conclude that over the next 10 years, what is it that we're going to see? What we will see is that there'll be a gradual diffusion of AI into medicine and surgery. You'll see more and more little tools pop up, which are AI-based. Bulk of the AI will function to augment the clinician rather than replace the clinician. And the third point, which I think is going to be very critical, is that the clinicians have to be involved in all aspects of AI, from development to the data that is being used to develop the AI, to evaluate it, to make policies around how AI should be used, and in deployment. So currently, we don't have that much clinical input. Typically, the AI is developed by, mostly on the technology side, by technologists, and it gets deployed. And it's up to the clinicians to basically use it or not use it. But unless clinicians get involved in the entire pipeline of AI development, it's going to be very difficult to make AI which is actually useful to the clinician, and also for the clinicians to understand what the limitations of AI are. So this is something which has been, I think, realized at a policy level in the US. And so there is a lot of interest in making sure that AI development involves both clinicians as well as kind of the AI people working in tandem to develop these systems. And with that, I think I'll conclude, and I'm happy to take any questions or comments.
Thank you, Shyam. Over to you, Dr. Bhandari.
Thank you, Shyam. At the outset, I must congratulate Vidya and Zipma team to picking up this subject, and you couldn't have had a better person to talk about it, because I consider AI as something beyond close collaboration, and exactly a new breed of clinicians who are dedicating themselves to AI with domain knowledge is the need of the hour. I have had a very detailed version of the lecture with Shyam with almost 40 minutes on 45 minutes, and I'm fully aware of his contributions to the field and look forward to more. My own involvement with AI is my own frustrations as a surgeon for 48 years. And I'm sure a lot of you would be surgeons in the audience and would relate what I say. Surgeons, even now, I've practiced here for 14, 13 years, and rest of time in different places in India, have a very poor predictive value with the current things. We have tremendously sophisticated investigations for knowing the infirmity the patient has or I need to fix up, but there is no translation in the form of interaction. Most of them are reference points or having 3D models or rehearsing what you want to do. But there is nothing, as Shyam used in one of the slides, is the GPS. There is no guidance to the surgeon. And each surgeon is fraught with uncertainty I do one surgical move. What would be the response of the body? I don't know. So that was one frustration I had. And I drive Tesla. I'm sure many of you drive Tesla. And then I realized what a predictability is. And if anybody knows, Tesla performs very well in 99.99 miles. Now they are focusing on 0.001 mile. And the amount of data they're collecting is 5.4 billion miles are logged every year from 500,000 or more Teslas across the globe. So this will give you an idea that what kind of data we are talking and answer the question which Shyam raised, that why there is so much of hype and a possibility and why there is a gulf between possibly in the implementation in medical care. The another issue which bothers is it is within the closed walls of operating room. Surgeons and anesthesiologists would agree that out of 300 million surgeries done, almost 3%, which is 9 million of them have complications. And the recent data point from Intuitive says that 1/3 of them will have to live with those complications. They are durable complications. And I am looking for AI to bring in more assistance to the surgeon. And this has happened. Anybody would have seen the next level robot, which is the intelligent decision-making system of Mako or Stryker, wherein the level of decision is finally to the human surgeon. But I talk to so many of joint replacement surgeons is they just feed and go by exactly what the robot says because they don't trust their own competence even with the experience, because the robots are so accurate in giving you the predicted ligament tension, size of prosthesis, amount of cartilage to be taken. And that is a glimpse into what it is going to be. The third thing, which is second, I said error minimization, and third thing is a very exciting field, and that's my primary interest. We are nowhere close, but we are at the cutting edge. Is democratization of surgery. Today, across the country or universe, even in United States, we look for excellence for whenever somebody needs a surgery, and we try to find out the best person in the field. So surgical experience is the major driver for confidence of the patient. And excellence is in pockets. It's humanly impossible for money man like person to operate anybody who wants him across the globe. But now AI gives a possibility that money man may not be available for everybody, but his data, his best practices could be turned into algorithms and which could guide the surgeons across. I'm not talking of telemedicine, I'm talking of immersive kind of things. Telemedicine, the AI has definitely given us a promise from gaming and cars. The technology is waiting there. But what is wanting is the clinicians have to rise to the occasions. And the first thing I would guide myself and Shyam discussed about the EMRs are the last word being considered in India or anywhere as a data capture. And EMR needs to be jacked up to match the data point levels we need for building robust models. I'll pick up on one more point with Shyam on, he alluded to the causation that AI has to be transparent and the black box concept. I think this is a natural tension between two approaches of the AI, where we are looking for hidden insights for huge amount of data. And I would be very happy if the models are very well validated. I care a damn why this happened. This is setting a too high a bar for AI in comparison to empirical medicine, or we call the art of medicine. The reason is that you are talking of 5 million data points versus historically collected 20 data points you use or variables you use for building logistic regression model. It is impossible. And we tried to meddle with, we built models with large, and then we wanted to personalize these models and try to intervene. We stepped down these models by looking for the frequency of the variable and it didn't work. It is something like you want an American family to behave as an Indian marriage system. So I think these are impossibilities, and I don't think there is a lot of work in decoding black box and all. I'll be very happy to have, but I don't consider personally as it is as it's a criticism. I would like Shyam to allude his views, and thank you very much once again for involving me in such an exciting discussion, and more importantly, putting me across to Shyam, who would have known, a long time ago when we were contemporary at Sigma. Thank you very much. Back to you.
So if anyone in the audience has any questions, please unmute yourself and speak up. And meanwhile, Shyam, if you want to, just respond to the points that Dr. Bhandari raised.
Sure. I'll respond to that last point about the idea of transparency and explanation for AI. So there's a spectrum on that. Is the reason we need transparency is basically to get trust of the humans. And once the trust is obtained, you don't need it anymore. So once the models work at a very high level, and this is what we see with airplanes, for example, the autopilot now works at such a high level that it doesn't have to provide explanations. And we trust the autopilot pretty completely. But for the interim, as these things come into use, people want some kind of explanation. So it's something just to get the AI systems into use. Now, there are certain conditions or certain applications where you don't need explanation. These would be like images. So when the AI tells you that there is a stroke on the scan and draws a picture, draws an outline and on. So there you don't really need much of an explanation because you can look at it and you can agree with it or disagree with it immediately. So I think as we go along, as the AI becomes better and better, we will need less and less explanation. Because once you're confident that the AI is performing very, very, very well, then you don't need an explanation at that point. So I agree with Dr. Bhandari there that eventually we want to get to a point that you don't need the explanation, because that is only going to slow you down with AI systems. Because if you want an explanation for every little thing that it's telling you, then it's going to take a long time to do surgery or to take decisions.
Dr. Ilango, would you like to say something?
The lecture was very interesting, but it's a little above my head. I'm just trying to understand the stuff. So it was an eye-opener. Thank you very much.
Amit, would you like to say something?
As usual, I mean, we only expect brilliance from two phenomenal speakers, Dr. Bhandari and Dr. Shyam Visweswaran. Dr. Bhandari actually did, I would say he built up on what Shyam said and really opened up a couple of things. When you're talking about democratization of surgery, there also has to be acceptance of what is valid in a culture and in a system. And if one were to use the AI, which one is going to develop in US in the next 10 years, can be really transported to India with all the cultural things. I mean, I don't want to bring anything else, but if you see what's going on in India with slight change of policies of the government for farmers and other things, health breaks loose. And I suspect we have to find out, is it going to be a push technique or a pull technique? What Shyam says, I completely agree about the trust, but a lot of people would think it's a push technique of there are people in high academic atmospheres who are understanding it, thinking this is for the good of the society, and they're pushing it in. while the others, and there are 5,700 medical hospitals in US alone, forget about the world. And a lot of these institutions have no clue of AI. And they have to be brought to speed very fast in the next 10 years, just in US alone. And then you're talking about the whole world, how to bring it up. That's going to be a challenge. And for leaders like Shyam and others, I would like to know what kind of educational policies or what kind of how do you run it in medical schools and curriculum, or even at higher levels, to have all the leaders buy into this? Because that's one of the things to buying into this. Nobody's buying into whether you can fly in a plane. We are far beyond that. Or Tesla. I mean, it's amazing to see the Teslas just drive out from the parking lot without a driver. And until unless you've seen it, you won't believe it. I've seen it, and it's very, very interesting. So it's going to happen with us, without us. I think the push technology, at sometimes the army way of doing it is what works. But I would like to know from Shyam and Dr. Bhandari, from the high level, when you talk about democratization, how should the people be educated to even accept it? Everybody sees the pain of electronic medical record system and how we lag behind other industries. But the acceptance is, am I going to be obsolete? Am I not going to be used? Are these technologies for learning going to be available in every institution? How somewhere in India, who are technically the best, the very best surgeons, and like Dr. Ilango, I've heard his talks, how do we get the technology there in an effective and a cost-effective way? I know there's a lot packaged into it, just a philosophical debate for me right now.
Yeah, I can probably touch on a few points. So there is a lot of fear and angst in the current medical students, at least in the university I'm in, because I go and give this talk to the medical students, and I usually have to stay on for another 3 hours to kind of answer a lot of questions. And the first question which comes up is, which specialty is going to kind of be taken over by AI, and make sure that I don't go into that specialty kind of questions come up. So existential questions. The second thing that comes up is, which I tell them, is that what it's going to do is it's kind of going to change your workflow more than putting you out of business. For most, I think, physicians, it's not going to put you out of business for a long time, but it's going to change the way you work. And for that, you have to know what these technologies are doing, how they're getting deployed, who is in charge of deploying them. And more, what we see, at least in the US, is that the leadership which is in charge of deploying the technology is very divorced from the actual clinical care on the ground. So they are looking more into AI for things like, does it decrease cost? Does it make billing easier? Rather than whether it's helping clinical decision making. And so, one of my advice to, at least for the students, is that they have to be involved right from medical school itself in understanding who is making these decisions and making sure that active clinicians get into those decision-making positions, and not be afraid that I don't understand the technology kind of stuff. Well, the guys making the decisions at the healthcare systems don't understand either the technology. They just go by what's told to them. So that's one point, is that the feeling of helplessness which is there among the medical students and the residents, really the only solution is they got to push into these leadership areas. And then the question comes up is, how the heck do I do it if I don't even understand what you're talking about? So this brings up the issue of dually trained people who are both trained in clinical medicine and AI. And we just have to do more of them and then put them in these positions of decision making. So they, right now, a lot of people who are dually trained like me, we're just sitting around in the research arena. And we don't really participate much in the functioning of the hospital system. So I think one area which is going to develop is there is going to be a cadre of people in the hospitals, similar to say, like antibiotic stewardship. So we have a cadre of people who are looking at antibiotics which are used in the hospital, resistance patterns which are developing, and they're constantly giving guidance to the ID physicians as to what's the right antibiotic to give at that point in time. And it's not like the ID physicians are going around collecting all the data. They just have a separate group of people who are doing that. So for all the AI products which are going to get deployed in a hospital system, we're going to need a cadre of people like that who understand both the clinical issues and the technology issues, who are constantly monitoring these AI systems, and they're providing on-the-ground guidance to the clinicians as necessary. And that has to be put in place for both safety as well as for making sure that, that they're clinically used. And I guess the third component to this is introducing some of this into the already very crowded medical curriculum. So this is an ongoing discussion in our university. And what's interesting is that for the past 10 years I've been involved in it, is the pushback always has been, well, they got to learn first the basics. All this computer business is like stuff which is beyond the basics of medical knowledge. And so we really don't need it. So it's never been put into the core curriculum. What happened last year was the students themselves, who are also part of the curriculum committee, they basically came up and said, we have been running this kind of course. So they basically have been running a course where they bring in people who are like me, using doing AI in medicine. And it's about 6 to 10 lectures that course runs, and we've been doing it for 5 years. And they basically came to the curriculum committee and said, they want this to be a critical part that every medical student learns. And maybe it should get compressed from 10 lectures to a couple of lectures. So, but they basically felt like this needs to be there. So there, I think there are many angles to this, and we need people at all levels. So we need to provide knowledge at the level of training, the clinical training. We need people who can advise the hospital leadership and who understand these technologies. And we need people who are dually trained and who kind of understand both of this to be far more involved in hospital operations, which currently is not the case. So it's, and the other thing I would like to point out is that even a research organization like NIH doesn't know or doesn't seem to understand that any AI has to be evaluated as rigorously as a new drug, because an AI has the potential to change what's done to a patient. A drug has a similar effect. And what do we do with new drugs? We put it through phase 1 trials, phase 2 trials, phase 3 trials, have FDA certify it, and then this post-marketing surveillance by the FDA. None of this is happening in AI. Someone develops it, someone sticks it into the system, and after that it's used clinically. You can't even pull up papers telling you about the evaluation which has been conducted on these systems. Like the one system I talked about, the large vessel occlusion detection system, which is now FDA approved and paid for the CMS. There is just one single evaluation paper on it. And it's not clear whether there's post-marketing surveillance being done on that system. And so we need top-down policy from at the level of the government, at the level of research organizations like NIH, at the hospital level, to basically understand that these technologies have to be evaluated through randomized controlled trials as rigorously as any vaccine or drug.
Thank you.
Vidya, can I ask?
Bandari, your
Yeah. Hello.
Yes, sir.
I think let me leave with a very happy note for most of us Indians. And I've been working, and I tell you, if AI major breakthroughs will come, they'll come from India. And the reasons why I say is the vast amount of data we generate and the skills of the surgeon. And there is awareness of collecting data. I'll give one example, Shyam. We have been building models on a funded project on live donor nephrectomy. And I looked at US, they do, in my own center, they do 30 living donors in a year with whole lot of IRB issues and all. And in India, there are 10,000 live donors done. We have already tied up with so many institutions getting their ethical clearances and working on it. Now, when it comes to building supervised models, besides what you rightly said about developing curriculums for undergraduates and all, I feel there has to be different strategy to involve them. Like labeling data is one of the major challenges. And for those who are not involved in it, your models would be as good or bad as your data is labeled correctly. If you say there are 10 structure, this is gonadal vein, and if it is not gonadal vein, don't expect the AI would make it a gonadal vein. So we did this with 3 laparoscopy transplant surgeons, and we found that these guys, surgeons are only interested in 2 things, including me: what is to be saved and what is to can be done with. They don't know the variations of gonadal vein. They don't know the branching of the lumbar vessels. Now, this is the best way, according to me, teach anatomy. And I'm trying to work with All India Institute, Jodhpur, to involve undergraduates in labeling the data. And I can guarantee if they label the data with their anatomical domain knowledge background, they would really get into the AI. So teaching, taking courses, I have done so many courses. And then finally, I got to the point until I sit with technicians, may not understand anything about his algorithms, his Python, I don't care. But I am with him in order to really have a little more understanding and get involved into giving the domain knowledge. So I think India is poised for it. All it requires is a data consciousness. Like if you see the surgical data we collect is so scanty for building the systems, wherein I read a paper from China where they recorded everybody in operating team and they tried to do the face recognition of some 40th person in the operating room to predict what the surgeon is facing in terms of difficulties. So when you collect the data, you don't try to assign whether it would be a value or not, which is very contrary to relational databases we have been working with. So I think it's a very exciting phase, but until you are in it, you would not be able to differentiate between what is a reality and what could be a reality because it has happened in other areas or other walks of life.
Yeah, I agree with that because one of the things about the current AI, so we are what I call the third wave of AI, and each wave of AI has got its own way of doing things. The current wave of AI is dependent heavily on massive amounts of data. That's how these models are built. And if you look at some of the top things that have been built, like the Google paper, which described about retinal images where they can very accurately classify the level.
Vinod Rathi has a question and somebody else.
So, Ravi, would you like to ask your question? I'll go through the chat box by then.
Sure. Shyam and Dr. Bhandari, great job. Thank you so much. I have a question for Shyam. You keep talking about post-marketing surveillance, and I guess from my unique vantage point, I can talk about the post-marketing surveillance from the FDA for drugs. And while it seems wonderful to talk about it, in reality, it's actually a pretty flawed system. The way it works is that anybody can report anything into that system, and meaning anybody, meaning any physician can report it. And the data that's collected is very scanty. So if you have somebody who took drug A, but also took drugs B to Z, you cannot attribute causality to any one, and they don't collect the rest of them. So it's very, very difficult. I mean, I find that whole system very hard to navigate. I find it creating more confusion than actual, useful information. Every time I look at something in a label that has, post-marketing events, I mean, my eyes glaze over because I always wonder, what's going on? Are there any other issues there as well? So how would you suggest that you avoid that kind of, noise collection rather than true data collection in post-marketing surveillance for AI systems?
Yeah, that's a very good question. Yeah, I know that in the kind of the pharmaceutical field, while the concept of post-marketing surveillance is great, its implementation is pretty flawed because everything is based on voluntary efforts in that data collection part. In the AI part, the FDA has been struggling with this. And so we have been having some conversations around how to do this. They do recognize that it's critical. If anything, it's more critical with AI models than with the drugs and vaccines. So one idea is that the organization which builds the model and then kind of licenses it or deploys it would be the one put in charge of making sure that this model is evaluated periodically. And then it would be up to them to say there's a big change or a small change that needs to be done and report that back to the FDA. So the FDA basically feels at this point that they don't have the expertise to do evaluation of AI systems. And also they're not set up to do something periodically at the rate of like several times a year. They're used to something like once in 5 years, once in 10 years. So on those two fronts, their feeling is that let's trust the organization which will actually do the modeling. So it's kind of like I guess the Boeing fiasco could potentially happen with that model. But that's the current model that they're thinking of is let the model builders be responsible for this, and they need to have best practices to model this or to do the monitoring and report it back. And there is a parallel for this in the software field. So in the past, a lot of the software that we use, like say the Office package, it used to be software that you bought and you installed it in the computer. And if you got updates, you kind of press your button and download the software and re-update it. Now we are moving to a model where you don't even download any software. You just use it in the cloud. And the advantage of that model is that any updates to the software can be done very fast. So Microsoft probably updates their Microsoft package on the cloud every night now, fixing problems and things like that. So that's another potential solution to the AI models, is that not push them out as software to the various hospital systems which are using it, but have them actually push the data over to the cloud where the model gets applied and then the results get pushed back. And that way, the models can be updated far more frequently. And if an agency like the FDA wants to develop expertise, it will be far easier for them to develop expertise. They just come to one place, they sit down with the technologists, and then they can talk about it. And they don't have to worry about different versions of the model sitting in different places. And there are also some technical issues about how you do model monitoring. A lot of the models are based on the supervised machine learning method where you get these targets, and the targets are often very expensive to get, just like Dr. Bhandari was saying. You need to annotate the data set very well for the target. And if you don't do a good job, then the AI model is not going to be very good. So for evaluation, in the naive fashion, you have to do the same thing. You have to get new data all the time and annotate it, and you could spend a lot of time and energy trying to do it. But we are actually many other groups are also working on trying to do this without annotations, at least be able to monitor without annotations. And if the monitoring system says that it looks like the model is failing, then you go in and re-annotate and do it. So there are some technical challenges also as to how you would do the monitoring, as well as policy and implementation challenges. But the thing is that it needs to be done. And the first step is for people to recognize that that it's important to be done. Because the models have to change as the population in the hospital changes, as the kind of patients who come in change. Because the models are often very sensitive to the patient mix you have. This is just like any standard biomedical research. Yeah, so there's a whole slew of issues to be solved. But the good news is that the FDA has been involved in this, and they've been thinking about this, and they're kind of reaching out to both policymakers, clinicians, informatics folks, AI people to figure out how to best kind of do this.
So while we discuss so many, really sort of advanced things, Lata has a very simple doubt. Do you think it's going to make the physician lazy?
That's an excellent question. So if you look at domains like pilots, and also now increasingly the people who drive trains, where the systems have been automated. So if you look at especially civilian air crashes in the past few years, bulk of them were due to what they call pilot error. So what would have happened is the AI basically transferred the control over to the civilian pilot for various reasons, and the pilots were rusty and couldn't take decisions. And typically when the transfer happens, the human pilot is handed a complex situation. It's not like an easy situation. And so what NASA has come up is with this idea, at least for pilots, is that some proportion of the time, the AI gets switched off and the pilots have to fly the plane. And that way they'll keep they won't get de-skilled. But this is a big problem, that if your AI systems become really good enough, then the humans will get de-skilled. And then when you get into conditions where the AI cannot handle it and the human has to make a decision, they are going to be pretty rusty at that point. Yeah.
When did you want to say something?
Yeah, I was saying, Shyam, now, if you talk about the transportation system, where you said that the autopilot or the auto transport was shifted to the manual, and aren't we being a bit unfair and saying that these skilled pilots were rusty? Because when it's a complex situation and the AI probably couldn't take a decision, well, we would expect complications with the human decisions as well. So maybe a fair assessment would have been to compare side by side what AI would have done and how many times would AI have failed, and then see whether it was really human error attributable. I can understand that people were sleeping and yes, they were getting rusty. That could be a possibility. But if the situation is complex, I think we must be fair in coming to that decision.
Dr. Ilango?
Thank you, ma'am. Dr. Shyam, there were two, our AI systems are very primitive. So my son is a computer science engineer. With him, I worked on an acute pancreatitis project in which the next step decision making at every hour was converted into a Python program, which was very useful because it's the way I was making decisions at the bedside. So we could convert that for 4 hours. So that was easy to teach and easy to implement. But the problem was getting it into a regular hospital information system where it will be actually useful. And is there a way to do that? The second thing is that I use the same Python program to teach ROTEM for nurses and for even for myself to learn the numbers very quickly. I learned in the US, so TEG was the common testing system, point of care testing system that was used. So when I came here to India, our hospital uses a ROTEM. So there was a learning process as well. So we used the Python program to teach. So those are the two applications which I worked on artificial intelligence. One is to make the process simple so that the nurses can run the process at the bedside. The second one was to use the artificial intelligence program to train and teach medical students and sometimes even specialist surgeons in particular fields, a narrow field. What are your thoughts on these things?
Yeah, so in terms of deployment, one of the things that we are stuck with is lack of standards. So our current electronic systems that we use in healthcare, they are a mishmash. Some of them use standard terminology, some of them don't. And part of it is driven by business decisions, especially in the US. For them, it's good from a business point of view not to have standardization because then they won't lose the business. So that needs to be changed so that all the data that we collect needs to be collected using standard terminology. So things like, say, medications, one of the standard terminologies is RX norm. And so you use RX norm to code those medications. Labs, similarly, there's LOINC, so on and so forth. So once your data, bulk of the structured data, forget the notes, but the data is in standard format, then what you can do is you can always pull that data out of the collection system, the EMR system, and then take it to the place where you can apply complex AI that you need to do, and then push back the results into the EMR system. So the current EMR systems is just too unwieldy to put AI technology into them. It just makes it more complicated. They become buggy, so on and so forth. I think the better way is to solve the problem technologically is to leave the EMRs as data collection and data display systems, and have the AIs running separately, and then have the data go to the AI and then push it back. And as long as the data comes out of the EMR systems in a standard format, we don't care who builds the EMR system at that point. Then you can take your AI software and hook it up to any system because the data is coming out. So the newest thing that's going on in the US is the FHIR interface, FHIR, which is basically a way that the federal government is starting to mandate that every EMR needs to be able to push its data out in a very standard form. And that way, we can take this data and do all kinds of things with it, not just apply AI. So I think that's kind of going to become critical. And and also the issue of the worry about data security. So at least in the US, the hospitals worry that if they put the data in the cloud, that it won't be secure and someone will get to it. And so they want the data to be sitting physically at their hospitals. We know more and more now that the cloud systems are, if anything, safer because they are being driven by big companies like Google and Amazon, who have been in this business for a long time, and they need to keep their data safe and secure. And if anything, there is more break-ins into the electronic systems in hospitals than into places like Google and Amazon. And so now there's a push for the data to go up to the cloud. And then once it's up in the cloud, then it's far more easier to kind of get your access to the data.
RK, would you like to say something?
Yeah, it's a very, very eye-opening and interesting subject, I should say. And I'm also quite happy to see Dr. Bhandari's optimism that AI will be coming from India, because I am one who believes that India is very high in technology, especially information technology, and it's very high in clinical medicine. But some of these two did not marry the way they should marry. I don't know where we don't come across each other. There is no place where we sit together. And who will be the catalyst? Will the government be the catalyst to bring these two together, or some pharma company? or some corporate hospital, I do not know, because that doesn't seem to happen. I haven't come across anybody from. Lucky that Ilango has got his son with whom he's interacting, but we generally don't see anyone.
See,
Yeah.
I think you raised a very pertinent question, and reason for my optimism, which may be totally false, so many of predictions are wrong, is that it is so easy to work. And AI is such a thing wherein so many players are involved. It is such an interactive thing. It is so difficult. If I want to go and talk to AI level statistician, he has to take permission and then he'll ask me whether I have IRB clearance or not. India, it is so easy to bring people. You have technological expertise, you have excellent surgeons, you have excellent hospitals. Now, the problem which is that who will do that? Now, anybody would have seen that I participated in Government of India's that Atmanirbhar Bharat a few months ago, and we had 1 month long debate, and I was in two groups. One of them was AI, another was robotics, and that gave me the showcasing what is strength in India. That triple ITK is doing something, IIT Kanpur is doing something, IIT Roorkee is doing something, but they are all in silos. So one of the recommendation is that you don't have to go anywhere, pick up the excellence wherever it is. And if there is somebody working on vision system, somebody is working on robotic tools, somebody is working on arms, bring them together and do the funding. So government has an initiative. I have seen a little bit of the budget. They have really budgeted. We don't know how much of that Atmanirbhar Bharat budget, which is separate head, is going to come to medical and healthcare. Now, how it has to begin is people like Shyam and we have to act as catalysts to generate. One of my mission every time I go to India, COVID, I couldn't come, otherwise I go 4 to 5 times to do. And I solicit meeting these hospital heads. And then I amazed to know what Narayan Hridayalaya is doing is amazing, or what Apollo is trying to do with their entire data is amazing. But until they are really, because they are tied up with Google and all, and there is always an intersection between data holders and those who know the value of the data. And that's where the problem arises. So my long answer to your short question is, it has to begin from everywhere. But I can tell you there is enough talent, which is, you should know that our company works with international people. We work with Pakistan, we work with Uzbekistan, we have Indian coders because we can't afford them in United States. It comes to almost $100 an hour to pay. It's just not possible. So take an example of your vaccine. Today, India did well in COVID vaccine because not that they were the front lines in designing a vaccine, but because they had the biggest vaccine production thing. So it doesn't matter. Don't kill your ego, but use your strength to bargain that we have our pie for our people. That's my thinking. Because if you chase molecular technologies or cutting edge things, what Shyam was talking, we would never have resources and we would never be able to match with it. But we should identify our strength and developing those strengths which would act as a big bargaining point when it comes to technology.
Yeah, I think one area where the US, I think, has done well is what we have in some of our universities is co-location of computing sciences and medicine. So a lot of the large universities, we are physically co-located, the computer science people, the AI people, the hospital people, and also there's training programs, like we have the so-called MD PhD training programs, which is a 8-year program where you do 4 years of medical school, 4 years of a PhD in something like computer science or AI. And that starts to bring people who are dually trained. So you need a few dually trained people to come in and kind of pull together the people together, because one of the projects I run, it's interesting, the dynamics of it is we have the domain expert, the clinician, we have the top kind of the AI guy, and I kind of sit in the middle who understands both sides, but I'm probably not an expert in either one anymore. And it turns out that I'm the most critical person because when I was off that team for a while because I was doing something else, by the time I came back, the computer science guy was doing something which is not what the clinician wanted. And the clinician was kind of very unhappy that the AI didn't do the magic that he wanted. And so I had to come in and basically say, okay, this is the problem that needs to be solved. And then I have to like tell the clinical domain expert that we are not doing magic, because he expected that it's going to do twice as better than him. And I'm saying like, well, our task is first to even get it to do as well as you can. So I think you kind of need that grouping of people, and maybe you need to have some training to be done. And given that in India, in many of the places, we have both. They may not be under the same umbrella. So you have the IIT and you have the hospitals in Chennai, but they're not under the same umbrella. But there must be a way to like say, we can train people who want to do both medicine and do something in IIT. And I think that would be at least one piece of it. It takes a long time to train them, but these people can be catalysts. So like in the US, one of the things they found out was some of the materials that is used for implants and orthopedic surgery basically came from two people who were trained both in orthopedics and in material science. So it's like two people making like 50% of the breakthrough in the kind of materials which were used.
I think for any breakthrough, what has come up, the 2 points I want to make. Number one is you need great leaders and great followers. You just can't have leaders. So I think the followers among us are trying to see the products coming up and disseminate. India can jump speed so fast with all the technologies it has. Once it sees some of the durable goods being created in other places, with all the brilliance that India has, it can duplicate it very fast. Number two, there is a curriculum change now for the medical students. They don't no longer have to slog that much. In fact, the USMLE has become pass and fail. So most of our medical school here in Mayo and others, they would give 8 to 9 months to these students to just prepare for the exam, because their residency was dependent on the scores they got in the USMLE 1, not 2. Now it's become pass and fail. So it doesn't matter. So they all have to do is pass. So this has opened up a lot of time for them, and school leaders are coming to us saying, how do we engage medical students? So things like AI and all the other new things which we had put in a shelf because we thought it would be overburdening, medical students are increasingly being interested in that. So I think you will see a huge manpower, Shyam, coming up, ground up. These students are already into gaming and other things. They can bring that science. So I think it is coming. There's a push technique going on right now. AI is here to stay, and the world has to accept it. They tried the pull technique for a long time. Nobody bought it, but I think that time of pull technique is gone. The next 10 years are going to be very fascinating, and we have to be very resilient and pliable. I'm a follower as far as AI is concerned. I keep my mind open to leaders like you to see what's going on.
Yeah, we are almost running out of time. Shiva, do you want to say anything? Shiva Pillai? I saw you raising your hand.
Yeah, first, it's nice to meet all you guys again. See you all looking so young and handsome still. But I want to say is that, Shyam, you will never get into this AI thing unless you start using it. I am doing fetal medicine now, and it's more predictive thing. And we are trying to say, how do we sift out the antenatal patients of those who are high risk as compared to those who are not high risk? And there's an algorithm with a whole lot of parameters that we put into it. The Fetal Medicine Foundation tries to predict which are the patients that will have Down syndrome, neural tube defects, Edwards syndrome, Patta syndrome. They go up to even predicting which patients are going to have PET. And we are trying to do that at 12 weeks. And they have gone through a whole lot of data to say, if you put in this data, you would have a predictive value. And at some point in time, it come back to what you say. When I started off, I looked at a patient, this patient, there's no indication that it would be a PET patient. But you start an ecotrin and you follow up the patient and you find out it is there. Now, the most important thing that came about them is that all of them use a particular program and all of us input our data into the same program. So when you become an outlier, when they will give you feedback to say, listen, the number of people you're predicting to have PET is more than those than we are seeing. What's going on? And they start to look at it, and you find that no, maybe it's a racial thing, maybe it's other factors that is, and the system, by the data that it collects from all of us using the same system, makes itself better. And I use that system, and when I started here in South Africa, I was one of the few guys started with it. It became crazy because we were using the system, and in the end, as I said, first you have a lack of trust, and then suddenly you trust the system totally. And if it says you that this is going, there's a high predictive value of this, you just believe it immediately, and all you have to do is to validate and follow up and see and correct. But I think that there's a huge use for it, huge value for it, but you'd have to just use it, validate it, and have the gold standard of predicting and measuring against what is predicted so that you know it works. I think you would benefit from speaking to a guy like Kipros and things like that. They're doing fantastic work in this. Thanks.
Yep. You bring up an important point that usually a lot of this is driven by someone at the right level in a hospital system getting interested in it and trying it out, and then it just expands out. So one example here was the head of critical care. He's always been interested in making clinical trials more efficient. The idea is that you want to learn from every patient and stop if the last patient provided you with sufficient data. And so he uses what's called an adaptive Bayesian trial with some AI built into it. And in fact, that technology was deployed to show that steroids work very well for the right kind of COVID patients. The only drug which has been shown to work very well. And it was done by this, and it took about 1/3 of the time that a normal trial would take because of this new way of doing the trial. But that was because he has been pushing it for about 5 years, and then he found this use case, and now everybody in the hospital system wants to use it.
Like Shyam said, when he gives a lecture on AI to his undergrad students, he has to stay back 3 hours to answer all their questions. Though we'd love to go on, we've been here for close to 2 hours. So I'm sure you will have a lot of questions. So Shyam, could you just put up your email again so that if anyone has any questions, they can.
Yeah, I'll put it in the chat.
Yeah. So thank you so much, Dr. Bandari, for taking your time and interacting with Shyam in advance so that the discussion was much more rounded and fruitful. And thank you, Shyam, for accepting to join us on a weekday. I'm sure you must be busy. And thank you everyone for joining. Though the topic is not really mainstream, more than 25 people were continuously on the Zoom meet, and several more were watching it on Facebook Live. So thank you everyone for joining, and we'll meet again next Thursday on another episode of Marvelous Medicine. Thank you so much.
There is one announcement I want to make.
Yes, sir.
Since all of us are interested in ZIPMER, and just to let you know that Vatikuti Foundation does a national competition on best clinical practices. And ZIPMER is one of the 8 top contestants, and Saturday would be the final declaration of 3 prizes. So I was so happy to see a complex liver surgery done with the robot, where I don't think there are many places in US. So it's so gratifying to know that what we have seen ZIPMER was general surgical level specialties developing, but now it's totally, that's why whoever I met, first thing I asked Shyam was that when did he go to ZIPMER last? So I think just to let you know, I feel so happy that it is giving tough time to 7 very, very serious contenders for this competition.
Thank you so much, sir. We have shared the link in our group, Learning General Surgery, as well as our JIPMANet Facebook pages, and I'm sure many of us will be looking forward to see who turns out to be the winner. Thank you so much, sir.
Thank you. Thank you, everybody.